Hello, this is Dr. Kim Jeong-gil. Today, in part 4 of the occlusal plane adjustment, we will look at how to orient the treatment from a MEIW perspective. When analyzing the occlusal plane in the MEIW diagnosis, it was largely classified into 3 categories. This is the measurement of the vertical distance of the level, yawn to lip line, the UOP angle of the cant, and the POP angle of the curvature. During diagnosis, observe the yawn to lip line. Dr. Ricketts said that the occlusal plane passes through the T point, the incisal edge of the mandibular incisors, and the embouchure of the lips. The first consideration in the diagnostic process is whether the vertical dimension is increased or not. The vertical dimension is largely divided into the anterior part and the posterior part, and it is recommended to increase it when the posterior vertical dimension decreases. Let's look at the relationship between the vertical dimension and malocclusion. The posterior vertical dimension becomes insufficient in the class 2 open bite, and the anterior vertical dimension is long. On the other hand, it can be seen that the posterior vertical dimension is sufficient in the class 3 deep bite, and the anterior vertical dimension decreases as the deep bite increases. Is it possible to reduce these in cases with long anterior vertical and posterior vertical dimensions? Unless surgery is performed, there will be limitations in orthodontic treatment alone. However, in the case of low posterior vertical dimension and low anterior vertical dimension, if the proper treatment direction is established, treatment is not easy, but an increase in the anterior vertical dimension and posterior vertical dimension can be obtained. Therefore, long AVD has a limitation of treatment. But low anterior vertical dimension can be increased through orthodontic treatment. In particular, in the case of Class 3 deep bite, treatment that increases the anterior vertical dimension is possible. Even for long PVD, it is not easy to reduce it except for surgery. However, in Class 2 malocclusion, much of the reduced posterior vertical dimension can be increased with orthodontic treatment. The second consideration in the diagnosis process is the location of the maxillary anterior teeth and the evaluation of the maxillary occlusal plane. We try to intrude the maxillary incisors when the maxillary incisors are overrupted, and try to extrude the maxillary incisors when the maxillary incisors are underrupted. Also, steep UOP will be flattened, and flat UOP will be steepened. It is recommended to evaluate the yawn to lip line and UOP together. If the maxillary incisors are underrupted, try to extrude the maxillary incisors. However, it is not easy to treat cases in which the maxillary anterior teeth are underrupted, while already showing steep UOP before treatment. Also, if the maxillary incisors are overrupted, it tries to intrude the maxillary incisors. Overeruption of the maxillary anterior teeth is associated with deep bite. However, if it is already flat UOP and the maxillary incisors are overrupted, treatment will not be easy. In general, in cases of premolar extraction, when the maxillary canine moves backward, the maxillary incisor is prone to be more extruded. At this time, when the maxillary anterior teeth are extruded, the UOP becomes more steepened. Anterior vertical elastics are useful in non-extracted cases with underruption of the maxillary anterior teeth. Even in the case of premolar extraction, the maxillary anterior teeth may be slightly extruded, so it is not bad. In non-extracted cases where the maxillary anterior teeth are overrupted, an intrusion archway is used to intrude the maxillary anterior teeth. However, in the case of premolar extraction in which the maxillary incisor is overrupted, it is highly likely that the maxillary incisors will be extruded, so care should be taken. Let's evaluate UOP together. In the case of non-extraction, which is a flat UOP, the force vector of the elastic force at which the maxillary anterior teeth are extruded is desirable. Even in the case of premolar extraction, it is possible to extrude to some extent the maxillary anterior teeth. In the case of non-extraction, which is a steep UOP, the maxillary anterior teeth must be intruded. In the case of premolar extraction, which is a steep UOP, the possibility of becoming more steepening increases, so care should be taken. If the UOP is normal, it is better to keep it if possible. However, steep UOP in deep bite should be changed to flat UOP. The main device used at this time is intrusion archwire. The deep bite is improved by intruding the maxillary incisors and extruding the maxillary posterior teeth. In other words, steep UOP is guided to flatten UOP. Intrusion archwire induces the maxillary molar extrusion and the maxillary incisor intrusion. Open bite has many flat UOPs. Flat UOP should be made with steep UOP, and the treatment force system is good for extruding the maxillary anterior teeth and intruding the maxillary posterior teeth. In other words, flat UOP is capable of steepening while intruding the maxillary posterior teeth through MEAW and making the maxillary anterior teeth extruding through anterior vertical elastics. Among the factors to be considered in the diagnosis process, the vertical dimension, the position of the maxillary anterior teeth, and the UOP were studied. The next important thing is POP. Steep POP should be flattened and keeps normal POP if possible. Steep POP is common in class 2 malocclusion. And in order to flatten the steep POP, the mandibular posterior teeth are intruded, and the mandibular premolar teeth are extruded. The appliances that change the steep POP of class 2 malocclusion include mini screws and MEAW with elastics. Both appliances turn steep POP into flattened POP. First, what kind of tooth movement will occur when using mini screws? As the total mandibular dentition moves posteriorly, intrusion and crown distal tipping of the mandibular molar occur. In addition, intrusion and crown distal tipping occur in the mandibular premolar region. At this time, the vertical dimension will be decreased. Is low posterior vertical dimension good for class 2 treatment? It is said to be good for conventional orthodontics. However, sometimes the low posterior vertical dimension is one of the factors causing class 2 malocclusion. So it is not desirable to further reduce the posterior part. What kind of tooth movement does MEAW with short class 2 elastics appear? Intrusion and crown distal tipping of the mandibular molars occur. This is a pattern of tooth movement similar to mini screws. However, the mandibular premolar is extruded, and the root performs mesial movement. This is different from the reduction of the mandibular premolar by mini screws. And the vertical dimension can be maintained while the mandibular premolar is extruded by MEAW. One of the characteristics of class 3 malocclusion is flat POP. Flat POP must be changed clockwise. The force system is the extrusion of the mandibular molar and a slight intrusion in the mandibular premolar. Mini screws and MEAW with short class 3 elastics can also be used for class 3 malocclusion treatment. Using mini screws, the total mandibular dentition moves posteriorly, with intrusion and crown distal tipping in the mandibular molar, and by intrusion and crown distal tipping in the mandibular premolar. At this time, the POP becomes flattened. In MEAW with short class 3, intrusion and crown distal tipping of the mandibular molar occurs. The mandibular premolar is extruded, and crown distal tipping occurs. Even at this time, the POP will be flat. In MEAW, we need to adjust MEAW to make flat POP steepen. The mandibular MEAW is controlled by the curve of SPE type, not the reverse curve type, so that the mandible molar teeth are extruded and the crown mesial tipping. The mandibular premolar are slightly extruded, and the crown mesial movement. Please remember that the mandibular MEAW needs to be adjusted when treating class 3 malocclusion. So far, the occlusal plane, malocclusion, and treatment strategies have been examined. In summary, deep bite of steep UOP should be changed to flat UOP, open bite of flat UOP to steep UOP. Class 2 of steep POP to flat POP, and Class 3 of flat POP to steep POP. Class 1 low angle, which is a normal POP case, should be maintained as normal POP if possible. Steep POP, high angle type, small combination factor. Class 2 malocclusion can obtain desirable results by changing the steep POP counterclockwise. I classified the occlusal plane into 9 types in terms of UOP and POP. In other words, you will be able to set up various treatment plans according to flat UOP, normal UOP, steep UOP, flat POP, normal POP, and steep POP. Flat POP is commonly found in Class 3 malocclusion. Steep UOP in deep bite. Flat UOP and steep POP in open bite. Normal UOP and steep POP are often observed in Class 2. I think you can look carefully at 3 of these 9 categories. Normal UOP, normal POP. Normal UOP, steep POP. Steep UOP. First, for normal UOP and normal POP, if possible, treat to maintain UOP and POP. And it is also possible to slightly steepening UOP. It is desirable to have the lower molars uprighted. In these cases, non-extraction treatment and premolar extraction treatment are relatively easy. The following is the case of normal UOP and steep POP. If possible, it is better to maintain UOP and flatten POP. It is possible for the maxillary incisors to be extruded and become a slightly steepened UOP. However, the mandibular posterior teeth must be uprighted and be moved forward. Non-extraction treatment is not very difficult. However, premolar extraction treatment requires great care. This is because the mandibular posterior teeth may fall more mesially inclinched while closing the extraction space. In case of steep UOP, the maxillary anterior teeth must be intruded to make the UOP flat and the POP flat. In case of non-extraction treatment, the maxillary anterior teeth can be intruded. At this time, the mandibular posterior teeth are uprighted and the mandible moves forward. However, caution should be exercised in cases of premolar extraction treatment. At this time, when closing the extraction space, the maxillary anterior teeth are more extruded and steep UOP may worsen. When classifying malocclusion, it will be helpful to classify the occlusal plane into three types: normal UOP and POP, normal UOP and steep POP, and steep UOP. Looking at the example of Class 2 malocclusion. In normal UOP and POP, the maxilla is protruded forward in many cases, and headgear or twin block can be used for non-extraction treatment. With premolar extraction treatment, only the maxillary premolar extraction can be done. Normal UOP and steep POP in Class 2 malocclusion often has the mandible retracted posteriorly. Non-extraction treatment can use a twin block to move the posteriorly located mandible anteriorly. In the premolar extraction treatment, you can extract the maxillary first premolar and the mandibular second premolar. In the case of the Class 2 malocclusion, which is a steep UOP, the mandible is often retracted posteriorly, and the POP may be normal or steep. For non-extraction treatment, it is desirable to use a double archway to intrude the maxillary anterior teeth. For premolar extraction treatment, it is recommended to extract the maxillary first premolar and the maxillary second premolar. At this time, delayed bonding is required for the upper four incisors to be attached later without attaching the bracket. The above will be lectured in more detail in the future diagnosis. Non-extraction treatment, premolar extraction treatment, and Class 2 malocclusion treatment. There are various types of malocclusion, such as open bite, deep bite, midline deviation cases Class 2, Class 3, and Class 1 malocclusions. First, look at the skeletal pattern and evaluate the condition of the occlusal plane. Largely, extraction and non-extraction can be determined according to the skeletal pattern and according to the occlusal plane analysis. It is possible to determine which teeth to extract and which treatments to be performed. Thank you for watching.